Kia ora koutou, nara te mihi ki a koutou. Kei te pai ki te tūtaki a koutou i o kano he ora e mene mai nei, nara te mihi ki a koutou. Ko taku nei mihi hoki ki te haukainga o tēnei wāhi no te atiawa, nara te mihi ki a koutou kua whakatau i a mātou i tēnei ata. Ko wai tēnei e tuaki i mua i a koutou, ko Michelle Mako tēnei, ko taku tūnga mahi ko te tākai Aranui Hauora Māori Tūmatanui. So in English, I'm the Director of Māori Public Health for the Ministry of Health, and it gives me great pleasure to be here with you today. So I did want to just take a few minutes to, I guess, do some framing about the importance of the research we're about to hear for the work that we do. As we'll all know, in Aotearoa, like many other nations, we have a rising problem of non-communicable diseases like cardiovascular disease, diabetes and cancers as a direct result of our diet. And as Professor Wareham so ably pointed out, individual interventionist mechanisms are only going to get us so far, and we are going to have to think a bit more broadly about some of the wider environmental determinants that are driving that diet. As we're all acutely aware, we're living in an environment which is driven by increasingly global food supply, where we have ultra high processed foods, high in fat and sugar and low in nutrients, that the distribution of these foods is not equal, and we have many communities who are having a preponderance of poor diet being sold in their community. These foods are conveniently packaged to make it easy for us to eat them quickly, and they last on the shelf for a long time. So as we've heard this morning, there is a need for us to think really carefully about the environments in which the food is occurring. We know that there are significant inequities in the accessibility of healthy, affordable food for Māori and for Pacific communities in particular, so we need to have a really strong focus on how we deliver that. But we also need a stronger focus on action to access of affordable, healthy foods through strengthening local food supply, restoring community food security and sovereignty, and we need to explore opportunities to improve the way that food is produced, marketed, and to elevate local and cultural knowledge systems about kai, as well as creating collaborative efforts to achieve healthier food systems. Professor Wareham also noted that we need to be thinking about how we move away from those interventions to those broad population health strategies, and how we use research and evidence to create the environment to do that. So what we're hearing is we need more and better research, and so the science challenge is timely because it gives us an opportunity to do some, as he described, naturalistic studies to understand what and how we improve the food environments that drive behaviours. And so with that, with great pleasure, I'd like to introduce the speakers for this morning. We have Professor Cliona Ni Mhurchu, who's an Associate Dean of Research in the University of Auckland's Faculty of Medical and Health Sciences, and she's also a Food Standards Australia-New Zealand Fellow. We have Magda Rosin, who's a PhD candidate at the School of Population Health at the University of Auckland. Dr Professor Cleghorn, who's a public health nutrition researcher in the Department of Public Health at the University of Waikato here in Wellington. And Dr Hemi Enright, who's a GP registrar who works here in Porirua and joined the Healthier Lives Sustainable Kai project while completing his Masters of Public Health. So it gives me great pleasure to introduce our speakers, and please join with me to welcome them to the podium.
Kia ora koutou. Thank you for the introduction, Michelle, and thank you for setting the scene. It's my pleasure and privilege as the leader for Theme 1 in the Healthier Lives National Science Challenge to give you an overview and a flavour of the research that has been done within that theme over the past 4 to 5 years. There are 3 themes in Healthier Lives, and Theme 1 is Healthier Food and Physical Activity Environments. And the premise, as we've already heard, expressed very eloquently this morning by Professor Wareham, is that the world we live in influences what we eat and how active we are. And arising from that premise came the question for our science challenge of could changes to food and our activity environments here in Aotearoa lead to better and more equitable health outcomes and lessen the burden of the non-communicable diseases that we're focused on in this challenge. Now, this is an image that you've already seen. Again, I'm indebted to you, Nick, for covering all of this so well, so I'm not going to dwell on it. But the basis for us focusing on food environments in the Healthier Lives Challenge, particularly in this phase, the second phase, was to actually see if we could shift the curve and to focus on benefiting individuals across our whole population rather than just the high-risk individuals who often receive a lot of attention in terms of obesity, diabetes, cancer and cardiovascular disease. But in terms of how we arrived at the research that's going to be presented here today, it was very much evidence-driven. So we started at the beginning of the 5-year phase with a stock take of evidence, policies and research. And this was a stock take that reflected the research that had been done internationally as well as local research here in Aotearoa. So that piece of work, which was incredibly comprehensive, led by Sarah Gerritsen, formed the basis then for a hui that was actually held here in Te Papa in March 2019. And at that hui, there were about 35 public health professionals, policymakers, and academics who spent I think it was at least a full day, if not longer, reflecting on the stock take and undertaking a prioritization exercise to identify what were deemed the priorities for Healthier Lives to fund in this particular area. And one of the key themes that emerged from that hui was the need to take account of policies that had already been implemented or were being implemented, or those kinds of natural experiments that perhaps were already underway, but that we didn't really have a good idea in terms of what impact they were actually having on the population, or indeed could have for policies or interventions that were not already in place. So within Theme 1, on the basis of that workshop, 3 major projects were funded, and you'll hear more about activation in the second part of this session this morning. I'm going to cover HYPE, the Healthy Policy Evaluation, which evaluated the implementation and impact of the National Healthy Food and Drink Policy. And Cristina and Hemi are going to tell you about the Sustainable New Zealand Kai project. So just in terms of the healthy policy evaluation, this is where we set out to evaluate the National Healthy Food and Drink Policy, which is a voluntary policy that was adopted in New Zealand, and to try and identify any improvements that had arisen from implementation of the policy. To give you a little context around why we decided to do work in this area, many of you may be aware that the World Cancer Research Fund has a framework for improving population diets with a particular focus on policies, but also system changes and those individual interventions that we recognise are equally important to run in parallel. So the Nourishing Framework is a really good way for countries to identify where there might be gaps in terms of policies that are already in place in other countries around the world and that have evidence to support them, but may not be yet implemented in certain countries. And you can see that many of the policies are areas that we might be familiar with, including nutrition labelling, the sugar-sweetened beverage taxes, or the fiscal policies that we've already heard about this morning, restricting the advertising of unhealthy foods to children, and so on. So in terms of New Zealand, we were aware that there was quite a bit of research already going on or underway in many of these areas, particularly around nutrition labelling and our health star rating system in New Zealand. So we very deliberately decided not to duplicate work that was already underway, but identified where there was a real gap, and that was around the offering healthy foods and setting standards in public institutions around ensuring that the foods that are available in those settings are healthy. And within that particular policy area, There is a sub-policy area around standards that are specific to health settings, including hospitals. Here in Aotearoa, there was a national healthy food and drink policy that was developed and published in 2016, and we thought it would be interesting to see what impact that was having. So the policy, I think the important thing to remember as we move through the research that we've done is that this was a voluntary policy. It's not uncommon in New Zealand. You'll be aware that pretty much all of our policies in the area of food, other than nutrition labelling standards, that most of them, if not all of them, are voluntary. So again, we thought that this was important because we felt that if this is the approach that's being taken to policies in our country, we should understand, what impact it's actually having. The scope of this policy is on food and drinks who are available for purchase by staff and visitors to hospitals and clinics, but not to inpatients who have very specific clinical needs in terms of diet. In terms of staff, we know that there are somewhere between 80 and 90,000 staff employed by Te Whatu Ora, so a pretty major workforce in our country. And that's not, in addition to that, there are all of the visitors to these sites as well. So any policy adopted could have a particularly large reach and impact. Within the policy, I'm not going to delve into a lot of detail because it's reasonably comprehensive, but the core of it is that foods can be classified using a traffic light system, green, amber and red, and the recommendation was that green foods should make up at least 55% of foods that are available in these settings, and amber less than 45%, and that foods that were identified as red, which are mainly deep-fried foods and confectionery and sugary drinks, that they should not be permitted for sale on site. I should say as well that a major ethos that underpins this policy is the idea that our hospitals and our health sector settings should be role modelling healthy eating in our country, so that it was deemed important for the health of our workforce, but also in terms of the messaging that's being sent through these settings. Sorry, the button's not working. Do I have a keyboard that I can... Oh, yeah. Okay, the keyboard's working. Okay, thank you. The evaluation had three foci, and that was to assess whether this voluntary policy had been adopted by hospitals around New Zealand, where it had been adopted, what was the level of implementation, how acceptable was the policy to staff and visitors, but also to food providers and retailers within hospital settings, and what impact was the policy having in terms of the type of food that was available for sale. Sorry, now I've gone too far. Okay, the first focus was on adoption, and so within this piece of work, we set out to collect policies from hospitals around New Zealand. At the time, we still had the district health boards, so 20 district health boards across our country. So we requested policies from all 20 district health boards and assessed them across three domains in terms of nutrition standards, how well they promoted healthy eating environments, and communication, implementation, and evaluation guidance. What we found in 2021 was that just 8 of the 20 district health boards had adopted the voluntary national policy. Remember, the policy had been first published in 2016 and was updated in 2019, but we still had fewer than half of the district health boards who had adopted the policy. That said, all of the district health boards did have a policy. It was just that some were electing to continue to use their own or were working towards adopting the national policy. Of the 12 district health boards that were not using the national policy, we found that most of them were not as comprehensive as the national policy, although some of them did have clauses that were actually stricter or aimed for higher standards. But what we concluded from that piece of work was that regional consistency was a major issue. We were finding that across the country where we had a national policy, we were seeing major regional differences in terms of the policies that were being adopted and implemented. And our recommendation on that basis was that the policy really should be mandatory. We then went on to undertake on-site food and drink audits, and those audits took place across a period of about 12 to 18 months. We did get a little bit slowed down by COVID, but we managed to complete the work nevertheless. We collected the data using a web-based audit tool that had an inbuilt algorithm where we were able to classify all of the foods that we entered as red, amber, or green. Of the 20 DHBs, 19 gave us permission to go on site and audit, so the data that I'm presenting are from 20 sites, because it was the 19 DHBs and the Ministry of Health. Of course, within each health board, there were multiple sites, so that meant that we visited 43 sites and collected data from 229 retail settings. When I say retail settings, most of those were actually vending machines, so 60% of those 229 were vending machines where we went and collected information about what was available there, and most of the remainder were the cafes or cafeterias, but we did also collect information from a range of other retail outlets, including fundraisers and non-traditional food retail outlets like pharmacies that still tend to sell food items. And we classified just under 8,500 drinks according to the policy. So going back to the primary outcome of interest, as I said, the guidance was within the policy that more than half, that is 55% of items available for sale, should be green, and there should be no red category items. What we actually found when we did the audits in 2021, 2022, is that 40% of the items that were available in our hospitals and healthcare settings were actually red. So that means deep-fried foods, confectionery, sugar-sweetened beverages. And around about 40% were amber, and only about 1 in 5 of products available were classified as green. There was no organisation that met the criteria. And again, we saw very notable differences by geographic region, probably reflecting the different policies that were in place, but perhaps also other local constraints and so on. In terms of equity, it was a concern that green items were significantly more costly on average than the red and amber, and that's something that came through continuously when we did our surveys as well. Of course, those audits were done at a single point in time, and in an ideal world, in an evaluation, you do have a baseline, and we would have liked to have a baseline before the policy was implemented. We couldn't identify any baseline data that we could use, but we were able to identify data that had been collected for the Informus study in 2017 from 4 Northern Region district health boards. And we were able to compare our data from 2017 to 2021. So although what we found in 2021 was pretty disappointing in terms of proportions of red, amber and green, what we could see is that there were slow shifts over time in terms of reductions in the numbers of red items. So in 2017, disturbingly, more than half the items available for sale were red, but that dropped down to just under 30%. And we saw a concomitant increase in the proportion of amber items. What we don't see is a very significant increase in the number of green items, and that may well be because of difficulties sourcing them. And also we see again, in terms of the work we did with retailers and providers, real concerns that they won't be able to sell those items or that people won't purchase them. We did small improvements over time, and particular improvements, I think particularly around drinks, where there were a lot of options for green and amber items, and also in certain areas within the policy where it was easier to identify amber and move from red to amber. We also undertook food provider interviews. This was a piece of work that Magda Rosin did as part of her PhD. Magda is going to be talking next. And these were, we were interested in the experiences of implementing the policy, what kind of support implementers received, and perceived customer response. So it was a small sample. Again, this research was particularly hindered by COVID, when our hospitals and our healthcare staff were really under the pump in terms of other priorities. But what we found overall was that there was a general acceptance of the policy and a real recognition that hospitals and healthcare settings should be leading the way in terms of providing healthy food. So definitely acceptable. But some key themes that came through in those interviews is that there are real challenges in providing healthy food options when providers are operating under several different policies and contracts. Bear in mind that providers often operate across multiple DHBs, and if those have different policies, that makes it really complex for the providers. They're also dealing with multiple different customer groups. So there are, although they're not dealing with inpatients, there are staff and there are particularly shift workers who are looking for particular types of foods at particular times that may not be necessarily aligned with a healthy food policy that perhaps has a perspective of 9 to 5. But more consistently what came through is that this was not a level playing field because it was a voluntary policy where providers elected to adopt the policy. They felt that they were actually then competing with other providers who didn't adopt the policy and were still selling those red items that were probably more popular, and so that there was an impact on sales. There was also a sense that the policy, again, probably because it was voluntary and because it wasn't accompanied by much resource or support, that it hadn't been sufficiently prioritised by the government or hospital leaders. And there was a definite preference that came through for a single mandatory national policy and for more support to implement that policy. We also undertook surveys with staff and visitors, very large survey of staff, over 2,500, very small number of visitors, again impacted by COVID at the time. And we found that there was very high awareness of, particularly amongst staff, but also reasonably high awareness of the healthy food policy amongst visitors, and reasonably good support. In fact, higher support by visitors for the policy as well. However, where there was opposition to the policy, the consistent theme that came through was that I should be able to choose whatever I want to eat and not have that dictated to me by a policy. So there were perceived changes in that people found that generally that there were more healthy food and drink options to choose from, but consistently that they were more expensive and that perhaps the portion sizes were smaller as well. So perhaps not such great satisfaction with that. Yeah, I'll probably leave that there. So our key findings in the HYPE study were that what came through when we triangulated all of the research we did is that because the policy is voluntary and there are no consequences for non-adherence, a lot of retailers just choose not to adopt it, and because they're worried about what will happen if they do. And so that's a major reason why, even where there's a policy in place, that we're not really seeing it having an impact in terms of what's available. Over and over again, we were told that there was a lack of resource to actually implement and monitor the policy. And to engage and secure buy-in from stakeholders and to work alongside food providers and retailers to actually help them identify healthier options. A lot of them had the policy. I didn't dwell on the complexity of it, but actually some of it is very, very complex to interpret and understand, particularly because a lot of it uses the Health Star rating system, which is another voluntary system and is not always on foods, and so that actually needs to be calculated where it's not available. So definitely, probably the policy as it currently stands is a little bit too complex. And we were told that there were challenges in sourcing healthy foods, possibly because there just isn't the demand for them, because there isn't a mandatory policy and therefore demand is pretty low. So our recommendations were that the policy should be mandatory because voluntary implementation had clearly failed, that tools and resources are needed to support implementation, and that more engagement was needed. And we also recommended that clauses were inserted into food retail provider contracts. This was not the case in most instances. And that priority settings, if hospitals wanted to focus on particular areas where vending machines and on-site fundraisers, which really pay very scant attention to a healthy food policy. So in terms of translation and implementation, you heard earlier that this is a key focus for all of our projects in Healthier Lives. Throughout the HYPE project, we worked alongside the Ministry of Health, Te Whatu Ora, to share our findings and to consider, how things might need to change. As we released our findings shortly afterwards, so in May last year, the Te Whatu Ora Executive Leadership Team actually endorsed the National Healthy Food and Drink Policy as a mandatory policy across Te Whatu Ora food services. They also supported the proposed implementation approach, including providing in-principle support for resources for policy implementation. The recommendation at that time was that all red items should be removed by the 30th of June this year. We will see. And that there be a review and an update of the policy because it is very complex and it probably needed to be simplified. So we were, you can imagine, as a research team, pretty thrilled to see the impact that our research had very directly in terms of policy and potentially healthier food availability. However, we have had changes of government since then, and we're unclear how much of what was endorsed at that time will continue to be a focus moving forward. We are, however, continuing to work with Te Whatu Ora to optimise the policy and implement, where we can, the HYPE study results and support tools. And in fact, Magda, who's going to speak next, is actually doing a huge amount of work to work alongside Te Whatu Ora on that policy revision and to continue supporting implementation. So, conclusions overall in terms of what I've presented so far. Successful policy implementation needs strong leadership. It needs resources to support implementation. A policy alone is not going to do anything. It's a piece of paper. And regular monitoring and feedback loops are important. We found that people were massively receptive to getting information back. We provided individual reports to all of the hospitals and retailers. They really enjoyed getting that information. We did co-design HYPE with policymakers and staff who worked in district health boards, and we think that co-design approach definitely helped lead to what we got as policy change last year. However, my overall reflection on the HYPE study is that the policy is just the beginning of a journey, and in terms of, I guess if there's a plea to any policymakers out there, it's to think beyond development of a policy and think about how a policy needs to be implemented and what support is needed to implement a policy, and not to lose sight of the destination, which is actually to change policy. So we have a national healthy food and drink policy, but I think the HYPE study has highlighted that it's pretty deficient in many areas. But I think there are ways that we could overcome that with better support, better resources, and a better focus on implementation. And with that, I'm going to hand over to Magda, who's going to talk a bit about what she did in her PhD, which focused on implementation.
Okay, kia ora katoa. Before we can actually jump into how we design and develop the tool, we needed to actually find out what tool was needed in New Zealand. So we done quite a bit of research behind it. We looked at the international literature, which told us that tools such as online training, recipe bank and analyzer, and product databases are important facilitators in implementation. And then we went and reviewed tools already available in New Zealand and Australia mainly, and there is no tool that supports the national policy. But that research told us what are the features and functions of typical tools. as well as their strengths and limitations. But then we still didn't know what tool was needed in New Zealand. So through the HYPE study, we found out what food and drinks are already available in hospitals, what are the current gaps and barriers when it comes to implementation, what tool could make the biggest impact, but also who are our end users, that's mainly food providers, and what are their needs. And as with any project, we also had to look at the cost of development and the budget, as well as our timeframes. So that puzzle gave us a clearer picture that the most needed tool in New Zealand was an online searchable product database. And you might wonder why specifically this tool. So let's go through a process and see how well you would do it if you were to classify a simple product like a cottage cheese with the policy criteria. So from the product packaging, you can find some information. You can find that this is a reduced or low-fat dairy product, which gives you already a clue here. And the HSR of this product is actually unknown because it doesn't display an HSR as a voluntary label. So what you would need to do is go and use an HSR calculator. Now, if we were to do that, we will have to go on a website and download an Excel calculator, and then find the nutritional information panel on a product packaging and find the specific nutrient values that we need. Then we need to decide which HSR category this product belongs to, then carefully and manually transfer the nutrient values into the calculator, which then gives us an HSR of 5. So if we look at the traffic light criteria, you can probably guess that this product is green. If you said green, you would be correct. But the HSR often require other information that the products don't have to display. And also, retailers don't only stock 1 or 2 products, they have tens or hundreds of products. And from the HYPE study, we also know that the retailers are stocking the same products across New Zealand. So potentially, this very troublesome process is going over and over again across New Zealand. What a waste of resources. So having a searchable database could limit that duplication of effort, that technical burden, also help food providers find products more easy and in a more feasible way. And this database could also support a more consistent implementation across New Zealand. So we teamed up with a product designer and we started developing our website. So the first step was what's called wireframes, which is just placeholder for where the information will go. Then we started to add a little bit more details and text, and then much more details and colors and pictures into what's called a high-fidelity prototype. Now, this prototype was created in a special program that helps us to mimic how a website would behave, and that was tested with end users, and their feedback further improved our prototype. So this is the homepage of our prototype as it is at the moment, and once it's fully developed as a website, this is how the tool will function. So you will be able to go and search for a product. For example, in this case, there are nuts, and that will give you a whole list of products straight away with the classification. You can add the product to your list if you wish. If you can't find a product, you can let us know. If you're a supplier or a manufacturer, you can ask us to add your products to the database after verification, and that just simplifies the process. But what's next for the tool? Well, we can always add more products to the database. We can add more functions to the tool. We can add additional policies that also use the traffic light classification system. But that's all dependent on ongoing funding. So the last piece of my PhD was actually identifying possible sources of funding going forward, and we found 2. One is the Te Whatu Ora, and the other one is Kaora Ka'ako Healthy School Lunches program, because their food providers would also like to have access to this database. And I think what's important is that if food providers and other implementers are spending less time on finding and classifying products, they have more time to spend on other initiatives, such as the Sustainable New Zealand Kai, which Cristina and Hemi are presenting on next. Thank you.
Thank you. Cool, thank you. Kia ora koutou. Ko Cristina Cleghorn tōku ingoa. I'm the PA of the Sustainable New Zealand Kai project, and it's my privilege to talk to you today about this project. So this is our team. We've got Nung Naim and Cliona on the left there, Bruce Kidd, who is a research fellow on the project, Hemi Enright, who will be speaking to you next on his master's dissertation, Cliona again, sorry, Cristina Mhurchu, who was instrumental in carrying out this project, and Andrew Reynolds, who also did a master's project on this project, and me. So I just wanted to start by giving you a bit of context to the project. This work sits in the health and climate co-benefits space. So we're looking for ways of changing diet and dietary policies that can support people to eat more healthy and sustainable foods. There's a couple of examples on this slide, but just to look at the consuming less meat circle, this impacts on climate change through reducing livestock production, reducing deforestation, and both these things reduce greenhouse gas emissions through both carbon dioxide and methane emissions. So this reduction in climate change has its own health benefits, but reducing meat intake also has those direct health benefits, reducing cardiovascular disease and lower rates of cancer. So this 3.5-year project had 6 different objectives, so a lot of work and sub-projects under each objective. So unfortunately I can't speak to you about all of this. So I'm just going to focus in on the kind of 2 aspects that I hope is of most interest to this audience. So firstly, the extensive consultation that we did as part of this, and secondly, the modelling work. So I'm just going to start by talking about the consultation. This was broken down into 3 stages. In the first stage, we did 6 focus groups with Ministry of Health, Ministry for Primary Industries, Ministry for the Environment, a local community group, a marae in Petone, and a focus group that we recruited through the steering group of the Healthy Families East Cape Kitchen Table Talks in Tairāwhiti. And this was to try and get some perspectives from Māori living more rurally. The focus of this first stage was to discuss what sustainable diets meant to these stakeholders and to get a range of policy suggestions of what could be implemented in New Zealand. We came up through this process with 111 unique policies, and then 14 of these policies went on to stage 2. So those were the policies that had evidence of effectiveness in terms of changing people's diets. Then the same stakeholders and our advisory group rated these policies on 5 different criteria, and the top 6 rated policies went through to the final stage of consultation, where we took them back to the same focus groups and interviews. Sorry, I forgot to mention we did 13 interviews as well in that stage 1 process. In stage 3, we talked in detail about each of the policies to try and figure out how stakeholders thought they should be implemented in New Zealand. The data from stage 3 was used in developing the policies that we modelled further on in the project, which I'll talk about shortly. But first, I'm hoping you can read some of those quotes. These are just a sample of the policies that were suggested, those 111 policies, and a few quotes of what people thought about them. So we divided the policies, we categorised them using the nourishing framework that Cliona helpfully introduced for me. 34% of the policies fell within the food environments domain, such as incorporating environmental sustainability into dietary guidelines. 17% fell within the behaviour change communication at the bottom there, and that's policies such as funding community cooking workshops. And then 49% fell within the food systems domain. And there were really broad policies suggested here, and they had a wide range of ideas, from establishing a ministry for food, reviewing pesticide laws, and supporting marakai. So these are the top-rated policies that came out of this process. We've got making healthy food and drink policies mandatory in all schools in Kura, supporting marakai and community gardens through providing resources and staffing, scaling up and resourcing the established garden-to-table programs in schools in Kura, educating the public about sustainable and healthy food through a mass media campaign, increasing incomes so people have the flexibility to choose healthy and sustainable foods, and removing GST from sustainable core foods. So now I'm going to talk about the modelling. I'm unsure how to make this play. Click again.
The idea of this health modelling. Imagine a large, finely tuned machine. Data goes in one end. Results come out at the other end. We can change variables on the machine to test different scenarios and ask ourselves, what if? For dietary modelling, the model is used to predict the impact of dietary policies or theoretical changes in food intake. Anonymous data on the population of New Zealand goes in one end. Then dietary consumption is adjusted to reflect the policy being modelled. Then the modelling results show expected changes in numbers of people with different diseases, the death rates and quality of life of those people, changes to health equity, the environment, and healthcare costs. The team uses existing evidence of effectiveness to form different policies, for example, removing GST on fruit and vegetables perhaps. The evidence is used to input any anticipated changes the policy would have on New Zealand's diet. For example, people eating more vegetables and less meat. Then the model will show them the changes in results. Less projected deaths, better quality of life, and healthier environment, for example. In addition, the model can also predict the financial costs or benefits of dietary policies. The cost of implementing a policy is calculated here. For example, the cost of changing the law, which can be compared with any changes in health system costs. Often, introducing a new policy might cost money, but would end up saving more money in health spending as a result. This is how evidence and actual data on all the people living in Aotearoa can be used to inform decisions about how we can improve our health, our environment, our spending. In short, how we can improve our lives.
Okay, so moving on to talk about some of the results of this project. As the video explained, we use this to look at the impact of both theoretical changes in dietary intake and policies that support people to consume more healthy and sustainable foods. So this is an example of one of the theoretical scenarios. We did quite a few of them, but I just wanted to present this one to you. It's the whole of the New Zealand population switching over to consume the Eat Lancet Commission's Healthy Sustainable Diet that was published in 2019. So I've matched this diet to our baseline diet, the National Nutrition Survey, and we can compare the baseline diet in the brown bars there with the Eat Lancet diet in the blue bars. So as you can see, under the Eat Lancet diet, there's a lot more vegetables and nuts and seeds. There's more fruit and whole grains, as represented by the bread and breakfast cereal bars, and also the grains are exclusively whole grain under the Eat Lancet diet. There's less poultry, potatoes, kumara and taro, and lots less sweet treats, red and processed meat, pasta and bread-based dishes. So we modelled the shift for the whole of the New Zealand population onto this diet, and we found really large health gains. So for every 1,000 people in the population, they gained 312 healthy life years over their life course. The reduction in disease incidence also saved really large amount of money for the health system, so 20.5 billion was saved over the life course of the population. Per capita health gain was higher for Māori compared to non-Māori, so 1.7 higher, or 70% higher for Māori. And the climate impact for the Eat Lancet diet was 57% of the baseline, so has the potential to reduce our nation's impact on the climate. So unfortunately we haven't got our policies illustrated yet, so we're just going to have to make do with a table. So we've modelled 5 policies, 3 in adults and 2 in children. I'm just presenting the results for adults here. So the policy that had the largest health gain was removing GST from sustainable core foods, and that gave a health gain of 23 healthy adjusted life years over the life course, and it saved $1 billion in health system costs over the same time period. The health gains were 40% higher for Māori. The next policy, educating the public about sustainable and healthy foods. This was also cost saving, so it would save $37 million. The health gains were small, but again, 60% higher health gains for Māori. Supporting marakai and community gardens was an expensive policy, as the stakeholders were really keen for there to be an employed person per garden to keep the gardens going. So if we employed someone at half-time, we found that this policy was cost-effective, but not cost-saving. So it would cost about $44,000 per each health-adjusted life year to run this policy, and would cost $360 million to the government. Again, small health gains, but 50% higher health gains for Māori. So this last policy is a good example of the scope of the cost effectiveness analyses that we are doing for this project. We look at the change in diet and how that impacts chronic disease, which is important, but it doesn't capture all of the benefits of these policies. And those wider benefits to individuals, whānau and society need to be considered as well. So the findings provide evidence for policymakers on policies that encourage consumption of healthy, sustainable foods and how these will impact our population health, health system costs and health equity. At this stage, there are obvious political barriers to implementation, but there is also widespread public support for change. So, for example, in this project, the policies that we modelled were considered by the stakeholders to be positive in terms of changes for Māori health, New Zealand diets, environmental impact. They felt that they would be relatively easy to implement and would have good acceptability. So we need to grow this public support while continuing to provide clear evidence of impact. So we've demonstrated that population level changes to dietary intake can generate large health gains, health system cost savings, improvements to health equity and positive climate impact. Feasible policies have been identified and designed by a range of stakeholders that could be implemented to improve the health of New Zealanders, and the policies that we modelled in adults were either cost saving or cost effective. When we're considering these policies, it's important to consider the wider benefits of the policies to food security, social cohesion, well-being, the local economy, the environment, and food system resilience. So I just wanted to say a big thank you to the stakeholders that took part in this project, and also the Sustainable New Zealand Kai team. It's been a pleasure working with you all on this project. Thanks to Toby Morris and Daylight for illustrating the project so far, and also Healthier Lives for funding this work. Just going to hand over to Hemi, and he's going to talk about the work that he did on this project for his master's dissertation.
Tēnā koutou katoa, ko Ngāpui, ko Ngātironui, rautou ko Ngā Ruahine toku iwi, ko Hemi toku ingoa. Kia ora koutou, I'm just going to lift this up a little bit. So I'm Hemi, I'm doing some training in public health and also working a bit in general practice out in Porirua, heading into work after this, so see how we go. My dissertation focused on exploring Māori views and connecting with Māori stakeholders and contributors in this project, and yeah, I just wanted to start by acknowledging the wider team and the support of my supervisors, particularly Cristina Ni Mhurchu, who comes from a dietetics background and who has whakapapa to the Gisborne Tairāwhiti region, and had all the connections and relationships already developed, and I just sort of slotted in there, went to the focus groups and became a part of that existing network of connections. So I just wanted to acknowledge Cristina. So in terms of the dissertation itself, this is kind of more of a lifelong kaupapa. It doesn't really fit into a narrow box or a kind of dissertation box. I'm glad that I got to explore this kaupapa and connect with these people across the country, but it's an ongoing sort of commitment that we're all a part of, and we've got an ongoing narrative or pūrākau that began, with our atua, with haumie, with rongo, in terms of our haumie and the ngahere and mahinga kai food sources, wild and foraged sources of food, and rongo in terms of the domain of marakai and cultivated foods. So this is kind of just sort of scratching the surface, and just wanted to acknowledge the wider kaupapa and how this is kind of a massive movement that's been going on for centuries and will continue to go on after this. So just in terms of framing the project, so a lot of the work in the climate, health and global warming space kind of creates a sense of humanity as a sort of homogenous group, but just wanted to acknowledge within that there's a lot of variability and there's a lot of power imbalances in different histories of different groups. So for us as Māori, as tangata whenua, there's the context of colonisation as an ongoing process that's severely impacted our ability to uphold te ao Māori rangatiratanga and enact key critical values such as the practice of kaitiakitanga over natural resources and whenua. A lot of work has already gone into this space, and I just wanted to acknowledge Jessica Hutchings, who's published extensively on this area and who I've relied on for definitions such as my definition of kai rangatiratanga, which is about the intentional act and expression of sovereignty over kai produced, consumed and returned to papa tuanuku. So again, reframing and acknowledging atua within that context. Also just wanted to acknowledge the work of Moana Jackson and Margaret Mutu with Mātaki Mai, and their work and Flax Roots engagement across the motu to talk about policy and how to reframe things in the context of te tiriti. So in terms of a brief review of the project that I completed, so we did a literature review looking at, I think, 7 or 8 different databases, and identified some key themes and spun that into a collective narrative on kai, and I've pulled out some of those themes. In terms of the presentation of themes, we tried really hard to not have any power imbalances between themes, so we don't go into sub-themes. Everything's sort of presented as being on a level playing field. Of course, this was a kaupapa Māori methodology with qualitative research methods in terms of key stakeholder interviews and focus groups, and the people that we had the privilege of meeting with and that contributed to this work were tangata whenua doing the mahi for whānau, hapu, iwi, in government and in regional initiatives around the motu. So in terms of weaving together the strands, so after I transcribed the data and coded it through in vivo, and then did the thematic analysis, some key themes that came out were talking about atua in relation to kai, so hence why the reference back and sort of walking backwards into the future, keeping our eyes fixed on the past in terms of referencing haumie and rongo. Then there was this a lot of reference to colonisation, so differentiating from that, we talked a lot about decolonising our palates, thinking more about the tastes that our tipuna were exposed to, like the yuck, the bitter, from like fern roots or kawa in the ngahere, and also deconstructing our palates in terms of what we're being socially conditioned to consume, which is mainly sugar, fat, and other stuff and takeaways in our obesogenic food environment. A key narrative that came through is talking about kai that is Māori rich. We've got some quotes from participants following this, so I'll sort of just let those contributors speak for themselves. We also connected back to the whenua and the moana and talked about consuming our landscapes, which sort of keeps us within planetary bounds and keeps us in relation to our whenua, and how we are, it's sort of in flux, continuing to shift towards rangatiratanga, which is actualising leadership and ownership of the space and moving away from decolonisation, which is more than the things that we see around us, but also the way that we view things ourselves. And something that I've had to really go into of this project is sort of reframing and trying to recondition my thinking, which has been affected by my medical training and being brought up in this country. So I've got some quotes from some of the contributors. So I'll just sort of go through these and let them speak for themselves. And we had Gabrielle Baker do the illustrations, and she's done a wonderful job. And catching up with her this week to do some more themes and illustrations for the project, for the next stage, which is dissemination. So kai was seen as being something broader than just the food in front of you or the portion sizes or eat more, eat less of this. It was something that actually, connected to your body, to your spirit, connected you to your whenua and your ancestors. So these are all direct quotes from the contributors. So flowing on from the analysis and recognising that we're just lightly touching on this, we came up with the recommendations at the end of the analysis chapter, and they were sort of centred around relationship building, and the key sort of idea being to listen to Māori for non-Māori policy actors working in the central government space, and also, looking at ourselves, understanding our positionality, understanding where we're coming from in that relationship to try and work towards something, working towards kai rangatiratanga, and acknowledging the responsibility that central government has in terms of having the collective resources and the collective mandate from the public to deliver on creating necessary conditions. And of course, listening to Māori and reframing and centering Māori views when designing initiatives in order to have the best impact on our communities. I just thought I'd end on that illustration as a very special kaitiaki species. Ngā mihi nui.